Good afternoon, everyone. So our next talk and speaker will be Dr. Yossi Unterslak, who specialized in obstetrics and gynecology. He also recently completed his Masters of Medicine, during which he extensively looked at the prevention of ovarian hyperstimulation syndrome. Give him a round of applause.
Thank you. Thank you. So Dr. Buerta just gave an excellent talk, and he finished his talk speaking about evidence-based medicine. And I'm going to speak on a topic that probably has the most conflicting evidence in the literature. So many articles that say one thing and then a body of articles that say something completely contrary. So I've tried to kind of simplify it and speak on really what is evidence-based. But you will see that some of my slides will say that this is something that's not evidence-based. So talking about recurrent pregnancy loss, we obviously have to start by looking at the definition of recurrent pregnancy loss. And this is where the conflicts begin, because the conflicts begin when we speak about the definition of what is a person who is suffering with recurrent pregnancy losses. So one of the definitions says this is relating to two or more failed clinical pregnancies that have been documented either via ultrasound or histopathology. And then we get a second definition which says a person is said to be suffering from recurrent pregnancy losses when they suffer with 3 consecutive pregnancy losses which are not required to be intrauterine. And these are just 2 of the many definitions relating to recurrent pregnancy loss. And this makes how we approach this topic very difficult, because how do we say we're treating somebody for a condition where the literature argues on what the actual definition of this condition is? So I'm not going to go into the slide very much because Dr. Buerta had the exact same slide in his talk. But I think it's important to recognize that 60% of conceptions terminate before a clinical pregnancy. So if an egg is fertilized by a sperm, 60% of the time this pregnancy will terminate prior to a clinical pregnancy. Where may they terminate? Either pre-implantation, so the egg fertilizes the sperm in the fallopian tube, and before the embryo arrives in the uterus and implants, it stops growing and terminates itself. Or the egg fertilizes the sperm fertilizes the egg, and the pregnancy arrives in the uterus, begins to implant, but fails prior to a clinical pregnancy. In other words, the woman doesn't even know that she's pregnant yet before the pregnancy fails. And of the 40% that make it to become a clinical pregnancy, roughly 10% will result in a miscarriage, and only 30% will result in a live-born child. So recurrent pregnancy losses is further defined as either being primary recurrent pregnancy losses or secondary recurrent pregnancy losses. And a primary recurrent pregnancy aborter would be somebody who has never had a pregnancy that's gone to viability. And a secondary recurrent pregnancy loss patient will be somebody who has had a pregnancy that's gone to viability and is now suffering with recurrent pregnancy losses. And interestingly, those are the patients which we tend to see more of. Patients who've had a baby, Dr. Buerta also mentioned it, who now suffer with 1, 2, 3, and maybe 4 miscarriages in a row. So what are the risks of a pregnancy terminating in a miscarriage? So in a woman who's having her first pregnancy, roughly 11 to 13% of these pregnancies will terminate in a miscarriage. But in somebody who's had 1 miscarriage, suddenly that risk increases to 14 to 21%. In a woman who's had at least 2 miscarriages, her risk of miscarrying is further increased to 24 to 29%. And once a woman has had 3 consecutive miscarriages, she now has up to 33% risk of miscarrying her 4th pregnancy. So you'll see from that slide that the more miscarriages a woman has, the higher the incidence of miscarriage in her subsequent pregnancy. So, when do we start investigating a woman who's had miscarriages? Because we've got all these definitions that differ, that essentially argue with when is somebody considered a recurrent aborter. So when should we start to investigate a person for recurrent miscarriages? So studies have found that women with 3 or more consecutive miscarriages, irrespective of whether that pregnancy was seen on ultrasound or not, so irrespective whether it was a clinical pregnancy or not, they have a much reduced prognosis in their fourth pregnancy. So most bodies of evidence will say we should only start investigating a woman who's had up to 3 miscarriages because her fourth pregnancy carries this increased risk. But I was asked the question, is it acceptable to allow a patient to miscarry her second and her third pregnancy before we start investigating her for her cause of her miscarriages? And I'm going to concentrate on this a little bit in the talk. And this is why I say the evidence is so difficult when you present a talk on recurrent miscarriages, because strictly speaking, we should only start looking after 3 miscarriages. And I don't see that that's fair on a couple to suffer their second and their third miscarriage. Another point that I think is important to discuss is that the cause of the miscarriage in the first pregnancy greatly affects the incidence of miscarriage in the subsequent pregnancies. So if we can find a cause in the first miscarriage that we can now do something about for the second and the third pregnancy and reduce that risk of miscarriage, surely it makes sense to start investigating after that first miscarriage. So what do I mean by that? For example, if one of the parents, the husband or the wife, the male or the female, carries what we call a genetic mutation, a balanced translocation, the risk of miscarriage in the next pregnancy is very, very high. Whereas if the cause of miscarriage in the first pregnancy happened to be from a uterine abnormality, the incidence of miscarriage in the second pregnancy, again, would be considered high risk. But when the cause of miscarriage is related to a sporadic chromosomal abnormality, which is the most common cause of miscarriages, the risk now becomes related to age. And that's why I think it's important to know what caused the first miscarriage so we can try and avoid the second and the third and the fourth miscarriage. So, what do I mean when I say that age is very significant when it comes to assessing patients for their risk of second or third miscarriages? So an excellent study looked at the risk of miscarriage in women relating to specifically their age, only looking at their age. So we said the background risk of miscarrying is around 10 to 11%. This study found it to be somewhere in the region of 11%. But they then went and divided the groups of patients who underwent miscarriages into certain age groups. They looked at the group of patients 20 to 30 years and found their risk varied between 9 and 17%. They looked at women in the group of 35 years old, and I see that yellow doesn't portray very well, but her risk of miscarriage was 20%. The woman in the group of 40 years and over had a risk of 40% miscarriage, and the woman over the age of 45, her risk of miscarrying was significantly raised, and 80%. So, again, importance of looking at all these factors when we're assessing women with recurrent miscarriages. So just to touch on a few of the causes of miscarriage, I'm not going to go into all of them. There are many, but the common ones that we see in our clinic, I'm going to discuss. And I'm going to start with uterine abnormalities. And why do I start with uterine abnormalities? Because it's such an easy pathology to pick up on an ultrasound, on a hysterosalpingogram, or on a hysteroscope. And it's something that's easy to pick up, easy to correct, and prevent a subsequent miscarriage. And it's responsible for 10 to 50% of miscarriages. And the abnormality that we see most commonly, the uterine septum, is responsible for miscarriage in up to 60% of pregnancies. What are the other things that we see? We see uterine fibroids, we see uterine scars or uterine synechia, and then not going to go into the incompetent cervix, but that's a common cause of miscarriages that we see in our patients, and that's more in the second trimester. So, uterine abnormalities, what are they? So we see a lot of different uterine abnormalities, some of them having less significant impact on miscarriage, and the most common one that I said that we see is the uterine septum. So how do these uterine abnormalities come about? So embryologically, a woman's uterus develops from 2 long tubes that migrate towards each other in the pelvis. They then fuse and then separate into 1 cavity and 2 fallopian tubes. And often, at that fusion, that separation of the two tubes doesn't take place. And a woman can actually have a condition where she has 2 uteruses, 2 fallopian tubes, 2 vaginas, and 2 cervixes. But more commonly, what doesn't resolve is that middle membrane between the 2 uterine cavities, and that we would call the uterine septum. And when a pregnancy tries to implant on the uterine septum, it fails in up to 60% of the time, something that is easy to diagnose and easy to correct. Uterine fibroids, a common problem, very common in Africa, but not always pathological when we talk about fertility or miscarriages. The fibroids that are located close to the endometrial cavity where the pregnancy goes are more significant, and they're more related to miscarriage and infertility, specifically the submucous fibroids, the intracavity fibroids. Those where they alter the endometrium that overlies them, and they can impact the chance of a pregnancy implanting. The pregnancy can implant abnormally and result in a miscarriage. What are uterine scars or uterine synechia or Asherman syndrome? These come about, Dr. Buerter spoke about the iatrogenic causes of infertility, those that the doctor causes, and these come about from the overzealous DNC. So we speak about the DNC when a woman has a miscarriage, and instead of the pregnancy passing naturally, she undergoes a procedure where she's put to sleep, and blindly the surgeon scratches inside the uterus to remove the products of conception. And the overzealous DNC causes this condition, which basically results in these pillars that connect the front and the back wall of the uterus, and they become stuck together, and they alter the implantation potential in the uterus. These are preventable in most cases, easy to pick up, and again, easy to treat in the right hands. Let's talk a little bit about immunological factors. Now, what are immunological factors? These are factors related to the woman's immune system. So certain immunological factors which can result in miscarriage. The most common one that we speak about is the one called antiphospholipid syndrome. Again, lots of bodies of literature differ whether this plays a role in recurrent miscarriages or not. But when we look at antiphospholipid syndrome on its own, the diagnostic criteria includes miscarriages. And so if an unexplained miscarriage is involved in the diagnostic criteria, surely it plays a role in itself in the miscarriage. And it's responsible for up to 10 to 15% of miscarriages in women who have antiphospholipid syndrome. Endocrine disorders, I'm going to touch on this, and primarily looking at uncontrolled diabetes. So uncontrolled diabetes, high sugar, certainly affects pregnancies, and it results in both congenital abnormalities in the unborn child, but also results in miscarriages. Uncontrolled thyroid functions, so either hyper or hypothyroid, also plays a role in miscarriages. Women with polycystic ovarian syndrome, a very common patient that we see in our clinics, we know that they have a higher incidence of miscarriage than the average population. And the debate lies in what is the reason for these women miscarrying. Is it because their eggs are poorer quality and they lead to chromosomally abnormal pregnancies? Is it related to their metabolic disorder, their high glucose, their high LH? And these are things that we debate about, what is the cause for recurrent miscarriages in the patient with polycystic ovarian syndrome. What we do know is that recent studies have suggested that metformin may reduce the risk of miscarriage, but a recent study, a very well-designed study, showed unfortunately that it showed no improvement in pregnancy outcomes in women with recurrent miscarriages. We touched on the thyroid and its role, whether under or overactive. Prolactin, the hormone related to milk, also been linked with miscarriages. It's been linked with an endometrium, a lining in the uterus which is abnormal, which results in miscarriages. The luteal phase deficiency, or what we call progesterone deficiency, which many people speak about, a 2015 committee opinion released by the American Society of Reproductive Medicine showed the following: there is no reproducible, pathophysiological, relevant, and clinically practical standard to diagnose this problem. and therefore we don't know which patients it affects and if it really affects miscarriages at all. And what we do know is that there is absolutely no evidence that has shown the replacing progesterone, luteal phase support in first trimester. There's no evidence that shows it to reduce the risk of miscarriage. Genetic factors. So, abnormalities in the number of chromosomes in the conceptus, the embryo that results when a sperm fertilizes the egg, make up the biggest group of miscarriages for sure, up to 50% of losses. What we also know is that having one chromosomally abnormal pregnancy appeared to increase the risk of subsequent pregnancies with chromosomal abnormalities and losses, and that the frequency of an abnormal pregnancy in a second pregnancy, if the first pregnancy was shown to be chromosomally abnormal, the risk of it repeating itself in the next pregnancy was 70%. If the first pregnancy was shown to be chromosomally normal, the risk of having a chromosomally abnormal pregnancy the next time around was only 20%. So, again, this takes me back to when do we start investigating a woman, and should we be looking for these things after the first miscarriage? And I'll touch on that in the next few slides. Inherited clotting disorders. So we investigate patients, thousands of rands, looking at things like inherited thrombophilias, protein C, protein S, protein G20210A. And the bottom line is that the evidence is very contradictory whether testing for this will make any difference, because if we find a woman to carry one of these abnormalities, it's pretty clear in the literature that treating these women with anticoagulation therapies, aspirin or Clexane, doesn't tend to change their outcomes in the end of the day. Does stress play a role in miscarriages? The question we get asked every single day. And again, there's no high-quality evidence, unfortunately, that shows a relationship in recurrent pregnancy loss between stress, environmental factors, occupational factors, and you'll see it says low-level exposure to environmental factors. There are certain environmental factors where excessive exposure has been shown to increase your risk in miscarriages. So, to talk a little bit about this new concept called the superfertile uterus. So who is this woman that we believe presents with a superfertile uterus? So she's the woman who tells you, if I have sex when I ovulate, I fall pregnant. But often, most of the time, it results in a miscarriage. Often these women present with a live-born child. I've had a baby, and since then, I fall pregnant and I miscarry, and I fall pregnant and I miscarry. And what has this been blamed on? So we think that in these women, the endometrium, which should play a role in filtering abnormal embryos from implanting inside the uterus, and if you'll remember that triangle slide which I showed before, that 60% of pregnancies, 60% of conceptions fail preclinically, and that's because of this endometrium that plays a role in filtering these abnormal embryos. And we think that in this woman with a superfertile uterus, that filtration system fails them. And so every conception implants inside the uterus, whether it's chromosomally normal or not, and results in a miscarriage. And that's what these patients present with: easy conception, early losses, or they present with what we call missed abortions. So they come for their 7-week scan, and there's no fetal heart on the 7-week scan. Again, the importance of how we diagnose, documenting the first miscarriage may help these patients prevent further miscarriages, because if we investigate these women and they're found to have an abnormal, chromosomally abnormal pregnancy, they don't require any further workup, because we could have stitched the uterus closed, operated 100 times on it, given them a box of Clexane and aspirin a day, given them lots of progesterone until their husbands ran away, and it doesn't change the outcome of the pregnancy. If the pregnancy was chromosomally normal, well, now we need to start maybe looking for other causes of miscarriages. Looking quickly at treatment options, and I'm really going to touch on this because the treatment very much depends on the cause of the miscarriage. So, if a person presents with chromosomally abnormal pregnancies, it's important, though, to still look for other causes, specifically those that are easy. the uterine abnormalities. If a woman had a miscarriage, it was chromosomally abnormal, she had a DNC or an evacuation of the uterus, and now has scarring inside her uterus, which puts her at risk of a subsequent pregnancy. Surely it's important to investigate whether this cavity of a uterus is normal before she falls pregnant again and loses that pregnancy. IVF and pre-implantation genetic screening will not increase the pregnancy rates in women who have large submucous fibroids. Women who have pregnancies, uteruses full of fibroids around the cavity, putting them through expenses of IVF, testing these embryos, but you don't address the real problem, the elephant in the room, the uterine pathology, it's going to make no difference to her outcome in the end of the day. And don't waste money testing things if we can't do anything about them. So we go and test these women for inherited thrombophilias, but the evidence shows that treating them doesn't make a difference in the end of the day. And this treatment is expensive. These investigations are expensive, and every cent wasted is hampering the chance of a person being able to do further IVF. What do we advocate for in today's day and age? So when a woman has a miscarriage, I think it's very important to diagnose whether this miscarriage was caused by a chromosomally abnormal pregnancy or not. Because as I said, if it was, nothing would have changed the outcome. If it wasn't, there are things that we could possibly do to change the outcome going forward. So what do? We do what we call hysteroscopic products of conception analysis, where we put a little camera into the uterus and we can directly biopsy the products of conception, the pregnancy tissue. And I always say it looks a little bit like coral when the water fills the uterus, and then you know you're testing the right tissue. We can then send that to the genetics people, and they can analyze that tissue and tell us this pregnancy was missing a chromosome, or this pregnancy had an extra copy of chromosome 21. And then we know what was the cause of the miscarriage, and we can stop looking for other causes. The other reason why we like to do hysteroscopic products of conception removal is because instead of blindly scratching inside the uterus and causing a patient to now have scarring inside a uterus, which is much more difficult to manage going forward, you can evacuate just as much as you need to, and then the uterus heals up nicely, and the woman can have an uneventful conception going forward. I think I'm short on time, so I'm not going to go so much into a case study which I was going to mention. Let's just touch a little bit on a couple of take-home messages. It's difficult to define what exactly recurrent pregnancy losses are because every organization has a different definition. And so it makes when to investigate these women difficult. Do we wait until she has 3 miscarriages? Do we investigate after 2? When exactly do we start to investigate these women? But as I said, I believe, why make a woman suffer 3 miscarriages if you can find simple things which are correctable after the first miscarriage and prevent this couple having to suffer through the second and the third miscarriage. Start by investigating the products of conception. It's easy to do. It gives you a lot of information, and it guides you on how much further to take your testing. And we have to consider age and overall fertility when assessing a patient with recurrent pregnancy loss. If a woman of 45 has an 80% chance of miscarrying her pregnancy, we approach that very differently to a woman who's in her 20s or 30s who has a 10 to 14% risk of miscarrying her pregnancy. And the reason is not because we are judging or treating the older woman differently, but because we accept that these conceptions are chromosomally abnormal, and that is why these pregnancies miscarry most of the time, and that it's probably unrelated to other causes. Thank you.